Thank you, everybody who stayed for this last talk. Sorry it's running a little late. So I'm going to be talking about Zika virus. And I think Zika is an interesting topic, especially because it's so new in the last year. And the Zika virus, what is it? It's a flavivirus that's very similar to dengue and yellow fever. And it's spread by the Aedes aegypti mosquito, which was, it's the most likely mosquito to pass on viruses to humans because it feeds off of humans rather than animals, whereas other types of mosquitoes will feed off animals as well. The Zika was named after the forest in Uganda where it was first identified. So the Zika virus, there's a map at the Center for Disease Control on their website where we can see where the primary infections in purple, where we're seeing documented transmission of the virus, South America, Caribbean, Central America. And in the past, Zika viruses were mostly in Africa, Southeast Asia. And so this is new to have the Zika virus in this area of the world. And the first reported cases were in Brazil in 2015, just May, which is just a little bit over a year ago, and it's spread since that time. And with the reports in Brazil, we can see that their reports that there's evidence of the link to, there's links to brain abnormalities in the baby. And so because of the link to problems in pregnancy and the abnormalities for baby, there's the World Health Organization declared this a public health emergency. So the Zika virus really, it's turned into, because it's spread to other countries, this pandemic. And when you have any new virus that is causing, these significant problems, especially in pregnancy and causing birth defects, there becomes a little bit of fear. And after the World Health Organization called this a public health emergency, you start to see pictures on TV, and they show pictures of babies with microcephaly. We don't know if these particular pictures are even related to Zika virus, but the news media finds pictures of these babies that have microcephaly and put it on TV, so that creates a little bit of fear. And then we start to see headlines in certain in journals, like The Lancet, in very good journals, that also instill a little bit of fear. It says, concern over Zika virus grips the world. It sounds very scary. And then an article blaming it on El Nino. El Nino is causing the Zika virus to spread. So we see, this fear factor. And then a lot of articles in the New England Journal that are linking this virus to abnormalities in the baby's brain, convincing us that this is a real problem. Additionally, in response to the World Health Organization declaring this a public health emergency and warning pregnant women of this risk, actually one group looked at the number of women that went onto the computer and tried to purchase medications for an abortion in countries where abortion is not legal. So what we see is in Brazil, there was a 100% increase in the number of requests for medications for abortions on the internet. And so this problem and this fear is a real concern. In Panama, there's not, I think the Zika virus hasn't been as prevalent, but there's still an increase of about 20% of online requests for medications for abortion. So there's a real fear among patients. So should we be worried? Well, if we take care of pregnant patients, we're definitely going to get a lot of questions, and I think there really is evidence to be worried. For one, because Zika virus is new to this region of the world, what it means is that all women are non-immune. They have no immunity, so they're all at risk of having an infection. Now, infections such as dengue, cytomegalovirus, rubella, they're not as widespread because people have immunity. We've been exposed to these in the past. But if we look at like rubella, 40, 50 years ago in the United States, it caused a very large outbreak of birth defects. So when these viruses are introduced into a new population, there is a very high chance of causing birth defects. So what happened in Brazil, like I said, this is recent, September 2015 to February of 2016, there was an initial report of 88 women with suspected Zika virus infection. Among them, 82% tested positive for the Zika virus, either in their blood or in the urine. Among women that had ultrasound, 29% had abnormalities for the baby. And the abnormalities included microcephaly, so very small head and small brain, and brain abnormalities. So brain abnormalities were the most common abnormality seen. There was a 20-fold increase in the rate of microcephaly in Brazil in 2015. Between November 2015 and February 2016, just 4 months, there was over 1,500 babies that were evaluated for congenital Zika, evaluations by neonatologists and pediatricians. One thing that is concerning is this article that looked at the rate of newborns that were evaluated for Zika by the neonatologists or pediatricians, and this spike is in November of 2015. So that peak area, November 2015, that matches up with the peak of the mosquito season, which was February and March, and then you go forward 9 months in the pregnancy to November, and there's a huge increase in the number of affected babies. So although things are very slow right now, and at the very end is closer to the present time, we're August, so we worry that by November there could be an increase in cases in other countries. And we don't know if Panama would be included, but Colombia is definitely concerned that they may see that increase. But currently the most affected has been Brazil. So how do we know this is going on, so there's a lot of education of how to prevent transmission, a lot of education for doctors to know what to tell our patients, but also educating the public. So, the most common scenario with dengue or chikungunya, yellow fever, is, you have a mosquito. You have a boy that's sick, the mosquito bites him. Then that mosquito bites a girl and then passes on the virus, and then she gets sick. Now it's still hard to control if it was purely from the mosquitoes, but we know with Zika that it's more than just mosquito transmission, and that's what's made it a little bit difficult to control. That yes, the most common way to get Zika virus would be from a mosquito, but there's maternal fetal, so vertical transmission. So somebody gets bit by a mosquito, but they're pregnant, so then the mom passes that on to her baby. Sexual intercourse, so if a patient has Zika virus, they have vaginal, anal, oral intercourse, they can pass on the infection that way. And then other common ways, blood transfusion, organ transplantation, laboratory exposure. So there's numerous ways for Zika virus to be spread, which makes it even harder. And Zika virus, when you look at patients who have the Zika virus, you can find the the RNA, the Zika virus material, just about anywhere in the body. You can find it in the blood, the urine, semen, saliva, female genital tract, spinal fluid, amniotic fluid, and breast milk. So it can be found just about any compartment in the body. The difference is that it is found in every part of the body, but not every body part transmits the disease the same way. For example, breast milk hasn't been shown to pass on to baby, but it is the viral material is there. If we look at blood, the Zika virus in non-pregnant patients, the virus is there for about 3 to 7 days, then goes away. In pregnancy, it's detectable for up to 10 weeks. So there does seem to be a problem that in pregnancy, women don't clear the virus as quickly. It persists longer. And then in semen, it's the same problem, that the RNA, the viral RNA, is detectable for 2 months after the symptoms are present. The female genital tract, the viral RNA is mostly present during the time of illness. So we look at these different sources. Right now, blood and semen are the two that have the longest duration of Zika virus RNA. People are particularly worried about semen and think that it may last even longer than what's reported here. Urine, saliva, and then the female genital tract. Even though the virus does persist in the body for a long period of time, the most likely time of transmission is in the first week after illness. So a couple problems, right? When you first have a mosquito bite, you may not have the symptoms right away. The symptoms can be delayed up to 2 weeks. So even if you have mosquito bites, you may not know whether you have the disease until a couple weeks later. The symptoms that have been primarily linked to Zika virus are low-grade fever, rash, that's itchy rash, red bumpy rash, joint pain, and conjunctivitis, right? Redness and swelling in the eyes. One problem, another major problem, is that symptoms are only present in 20-25% of women. That means that 75% of people that have Zika virus don't have any symptoms. So that makes it very difficult. When clinical disease does appear, fortunately the disease itself is very mild for the most part. When women have Zika virus, it only lasts a couple days, but of course the concern is with baby. We consider someone to have clinical Zika virus if they have at least one symptom, although in a country, if the Zika virus is not endemic to your area, then usually we require 2 symptoms. So I know in the US, when we're doing screening, we have to have 2 symptoms because some of these things are pretty common and we don't want to overdiagnose Zika virus. So how do we prevent, what do we tell our patients? They say, well, I want to travel, I want to go to this country, I want to go to the Olympics in Brazil. And what do we tell them? Well, certainly if there's a high risk of Zika transmission in a particular area, women who want to become pregnant or who are already pregnant should limit or avoid travel to that area if they want to do the safest thing possible. Of course, if they are in an area where there's transmission, then they want to adhere to mosquito protective measures, which we generally know, the protection of the long sleeves and pants, the insect repellent, the DEET, which is considered safe in pregnancy. Of course, when possible, doing work indoors, and use of mosquito nets and window and door screens. So common sense things to prevent mosquito bites. So in the United States, we don't have a lot of Zika virus, but there's been a couple cases. And in Miami recently, there was some cases of Zika virus. So this is just an example of what we do to alert the public. So after we had a couple cases in Miami, the Center for Disease Control posted this map on their website, and they included this red box to show people where the Zika virus was taking place. And luckily in Miami, it was a very small area, so they could contain that area. And then this particular area was called Wynwood. And they said, okay, we're going to give advice to people who are traveling to Wynwood. Luckily, it wasn't near the clubs or beaches, so they were okay. But what they told women for this particular area is that they should not travel to the area, take precaution to avoid mosquito bites, that anybody who lives in that area should use condoms to prevent sexual transmission. So if you live there, or you're traveling there, or you have a partner in the area. And anybody who's pregnant who lives in that area or travel to that area should have Zika testing in the first and second trimester. So this is actually what was done in this case, and this was only a couple weeks ago. So what are the recommendations prior to pregnancy? Well, what if someone did travel to an area where there's a lot of Zika virus and they actually got sick and they had a rash and they had a fever? They're not pregnant, but they want to become pregnant. The recommendation is to wait 2 months. So if you actually have confirmed Zika virus, the recommendation is to wait 2 months to try to get pregnant. Now that's for women. Because they're worried about the semen, they want men diagnosed with Zika to wait 6 months. So if a male has Zika virus, they should not try to conceive with their partner for more than 6 months. Well, what if, and this is probably the most common, that a patient comes in and she says, either she traveled to an area where there was mosquitoes or her partner traveled to an area with mosquitoes. They had mosquito bites, but they don't have any symptoms. What should they do? They want to have a baby. They're supposed to wait 2 months. They're supposed to wait 2 months before trying to have pregnant, even if they never had any symptoms. Basically 2 months from the time that they had possible exposure. Now this may not be possible if it's an endemic area, meaning if you're in an area where there's continuous exposure, even if you wait 2 months, you still have the same risk because you're continually at risk. So you can imagine it gets very difficult if you identify mosquitoes in your area that carry the Zika virus. Okay, what about now you're already pregnant, so the patient comes to you and they're pregnant already, but they live in an area where there's Zika. Now, if a woman is pregnant and she lives in an area where there's Zika virus, she's instructed to abstain from unprotected vaginal, anal, or oral sex the entire pregnancy. It doesn't say abstain from intercourse completely, but condoms should be used throughout the entire pregnancy. Well, what if you don't live in an area with Zika virus, but you're pregnant? So, which is still possible, like in Miami, that is not a typical area with Zika virus, but it can happen. So if a woman has Zika disease, but she lives in an area that is not usually affected, she should wait at least 6 months before having unprotected sex with her partner. This is in pregnancy, more or less the whole pregnancy. I would say if someone is pregnant and they have Zika disease, probably should wait the whole pregnancy before having unprotected intercourse. If they're exposed to Zika, but they don't have any symptoms, then the recommendation is to wait 2 to 3 months. So this is also a very common scenario, again, where a pregnant patient goes to Brazil, Rio for the Olympics, has a couple mosquito bites, no symptoms. What should she do? She should wait a couple months to have intercourse with her partner. So it's important to know some of these recommendations because the situations come up quite frequently, especially with people who are traveling. So, why is this so important? We know because of the risk to baby, and we have to have an accurate screening and accurate diagnosis. The Zika virus in pregnancy is associated with pregnancy loss, stillbirth, growth restriction, microcephaly, and brain and eye abnormalities. And Zika has been transmitted to baby in every trimester. So there's really no trimester of pregnancy that's safe. And we talked about that Zika virus is really found everywhere. It seems that the most common place for Zika virus is the brain. And when they look at babies that have passed away and look at the different areas in the body, the brain tissue has the highest concentration of Zika virus. So there's some limitations to screening for Zika virus. There's no treatment, so we can screen for it, but we have nothing we can do about it. We don't really know what the exact risk is of vertical transmission. We can't really say what percentage of women with Zika virus will have babies that are affected. We don't really know the time from infection until the time of ultrasound findings. We don't know if it's a couple weeks or sometimes can it be delayed a month or two before we see signs on the ultrasound. Ultrasound findings may not be apparent until the 3rd trimester. So in areas where termination of pregnancy is allowed, it's still problematic because we don't know until late in the pregnancy. We don't know how accurate the blood testing is. So we can get maybe false negatives or we can get false positives. So what do we do in terms of testing? First, we'll look at if we're in a non-endemic area. So we're in an area where there's no Zika virus, that there's not a lot of transmission. So you have to ask your patient 2 questions. Do you live or have you traveled to an area where there's Zika transmission? 2, does your partner live or has he traveled to an area with Zika virus? So either one. If the answer is no to both questions, then you're done. You don't need to do any testing. So that's the easy part. But if either the patient or her partner has traveled to an area where there's Zika virus, then you have to screen for symptoms. You say, do you have, in the past 2 weeks, have you had fever, rash, joint pains, or conjunctivitis? If yes, you have to test for Zika PCR. If the patient has had no symptoms in the past 2 weeks, then you say, well, did you have this exposure in the past 3 months? If yes, even if they don't have any symptoms, you have to send for Zika IgM antibody. So that's very important. If they travel to an area where there's Zika, they said, 6 months ago, I was in Rio de Janeiro, I had mosquito bites, but it's been 6 months, I have no symptoms. What do I do? No testing, because it's been more than 3 months. So if it's been more than 3 months, no testing. It's a little bit different if you live in an area where there's endemic, where there's ongoing Zika virus transmission, because you're exposed all the time. So really, if you live in an area where there's active virus, when you have this first question, everybody will answer yes. The question to everybody is yes. Nobody will answer no. So that's why everybody has to be tested in that population. You still have to screen for symptoms, because the difference is, if they have symptoms, you're going to do the PCR testing, the right testing for Zika RNA, versus if they have no symptoms, you're going to do the antibody testing. And in an area where Zika virus is active, everybody who enters pregnancy needs a Zika antibody test. That's the recommendation. So what kind of testing? I talked a little bit about that. The main difference is, if you have symptoms within 2 weeks, you need the PCR molecular RNA testing in blood and urine. It's important to draw 2 blood samples, because the first blood sample is going to do the PCR for RNA. If that's negative, then you have to send the second blood sample for antibody testing. So you always have to draw 2 vials of blood, and you have to send the urine. There's many women who have a negative blood test but a positive urine, so that's why that's important. If you're in that window of time between 2 weeks and 12 weeks of exposure, then you do the antibody test. So you only do the RNA test if it's been within 2 weeks. Everybody else gets the antibody test. Now, a lot of people say, well, yeah, the main concern is the antibody is cross-reactive with dengue virus, yellow fever virus. So what do you do about that? Because if you're in an area where you have, let's say, dengue, and you have a positive Zika IgM, you still can't be sure if you have a Zika infection or dengue infection. So you have to do what's called plaque reduction neutralization test, PRNT. That's to help differentiate between dengue and Zika. If you have, well, I'm going to show you the table here. If you do this test, the PRNT, the plaque neutralization test, so anybody who has a positive IgM Zika, you do this test. If your titer is over 10, that's for Zika, because this one is now specific for Zika or specific for dengue. If your titer is over 10, and then your dengue titer is less than 10, so dengue less than 10, then that's basically confirms Zika infection. If you do this test and your titer is less than 10 for Zika, but it's greater than 10 for dengue, then you have dengue virus and not Zika virus. So that's a very important step. Now, if you're in an area like in the United States, we don't do this part because we don't have a lot of dengue. So it depends. We would automatically assume that it's Zika virus infection. So it depends what type of viruses are common in your population. If you have yellow fever, then you have to do the same test for yellow fever. So now, what do we do? Positive test. We did all the confirmations. We're pretty sure this is Zika virus. You have to do an ultrasound. We said there's ultrasound findings. You really should do it soon, within a couple weeks. If the patient is under 14 weeks, the recommendation is to measure the baby, the crown rump length, the bipyramidal diameter, the head circumference, and try to look at the anatomy. If the patient is over 14 weeks, then we want to do a full anatomy. We do the measurements of the head, the abdomen, and the femur, but we also want to look at the brain, right, because there's mostly brain abnormalities. So the ventricles in the brain, we want to measure the cerebellum, and we want to look for calcifications in the brain. So calcifications both in the brain and around the ventricles, very common. We see that with cytomegalovirus, very distinct bright spots in the brain. If there's no abnormalities on the ultrasound, you have to follow up in 4 to 6 weeks. If the ultrasound looks abnormal, you have to repeat sooner and obviously have consultation with maternal fetal medicine and make a plan. If you're doing testing on a patient and they're negative for Zika, what do you do? If you're in an area where there's not a lot of Zika virus, you don't have to do anything, routine prenatal care. But if you're in an area of high risk, you still have to do your high-risk ultrasound at 18 to 20 weeks. So you're still going to be looking for all of the same things that I just mentioned, but it's going to be more routine surveillance. But because you're in a high-risk area, there's a chance you may see something on that ultrasound. And if you did find an abnormality on the ultrasound, then you have to repeat the Zika testing. So even if someone had a negative test, if you see a brain finding on the ultrasound, repeat the Zika virus test. Right now, there's no recommendation to do amniocentesis. The amniocentesis is really not necessary because if mom has Zika virus in her blood, or there's ultrasound findings, the baby is affected. If someone felt that it was really going to help them make a decision whether to terminate the pregnancy, that might be the only scenario where it's beneficial. So what are the ultrasound, what do you do on ultrasound? The biometry, abdominal circumference, head circumference, femur length, ventricles, measure the cerebellum, look at the cisterna magna and the cavum. So we're looking for abnormalities in the brain. The hard part is, what's a small head? What do we define as a small head? Some people say 2 standard deviations below the mean, and some people say 3 standard deviations below the mean. In the United States, we're using 3 standard deviations below the mean. Other findings on ultrasound, the cerebellum, if you measure the cerebellum, it'll be small. The ventricles will be large or abnormally shaped. There'll be calcifications around the ventricles. The cisterna magna will be large. The cavum, septum pellucidum will be absent. And these are some of the things that you would see potentially that could represent Zika virus. Enlarged ventricles. Calcifications in the brain. This is a sagittal view. The ventricles here, and then the calcifications are here, very bright spots in the brain. The cisterna magna will be enlarged, can be enlarged there. So those should alert you to the possibility of Zika virus as a possibility. So microcephaly, we said more than 3 standard deviations below the mean. If you use 3 standard deviations below the mean, that's significant. You can clearly counsel the patient that they're at risk for brain impairment, that the brain development is impaired, that they're high likelihood of having neurodevelopmental impairment, physical impairments. If you use 2 standard deviations below the mean, some of those patients will actually do very well. So you have to be careful if you counsel those patients. But if we use 3 standard deviations below the mean, that's clearly a high risk for these complications. So this is a patient that I saw in my practice about a month ago who came in for a small head, got referred in for microcephaly, and we measured the head circumference. And she's supposed to be 34 weeks and 5 days. But the head circumference was only 29 weeks. So a 5-week lag seemed pretty significant. So what do? In Oregon, we haven't had many cases of Zika virus, but we still have to go through the screening. So of course we ask about travel, but we also we have a table and we say, well, let's take the head measurement. It was 266 millimeters. And you plug it into the table. We look, okay, 34 weeks, 266 millimeters. That's 3 standard deviations below the mean, right? So this is 1 standard deviation, 2 standard deviations, 3 standard deviations less than expected. So we have this table in our ultrasound unit, and that's how we determine whether we're 3 standard deviations below where we should be for that time in the pregnancy. So this is diagnosed with microcephaly. It's confirmed based on this table. So what do? We look at the ultrasound and we say, what other findings do we have? One, we have an abnormal profile. If your head is 3 standard deviations below the mean, usually the profile is not normal. So you have the forehead is sloping forehead. It's not straight up and down. When you look at the ventricles, there's a calcification. So the ventricles here, all along the border of the ventricles, there's calcifications, and we see it in the sagittal view as well. And the ventricles are enlarged here. So that looks a lot like Zika virus, right? Except, I mean, the only thing is that we're in Oregon, so we don't have a lot of Zika exposure. But this is cytomegalovirus. So the thing is, cytomegalovirus and Zika virus have very similar ultrasound findings. So for those of us that have seen patients with cytomegalovirus, it's very similar ultrasound findings. We tested for both. It was the Zika virus IgM was negative, and the CMV was positive. So it's just important to remember that some of the viruses can have very similar ultrasound findings. So what do we do for the infants and following these pregnancies? Well, if there's a stillbirth or pregnancy loss, we should be sending the tissue for pathology. If there's any tissue that can be sent for genetic testing, histopathology, immunohistochemistry, it should be sent. Some of that is for research purposes, but some of it is for counseling for future pregnancies. If a mom has Zika virus, even if it's confirmed, currently the Academy of Pediatrics is still saying it's okay to breastfeed. So actually, even though the Zika virus RNA can be found in breast milk, it's still okay to breastfeed. It's unclear how long babies should be followed by neonatology or pediatricians, but I would say most neonatologists are going to follow these babies similar to babies that have been affected by cytomegalovirus, because those babies can have long-term implications over time, so they really have to be monitored closely. So in conclusion, Zika virus, it is real, it's ongoing. It's hard to tell if it's going to impact, say Panama or the country where you live. So it's important to follow the news and follow the reports of where the Zika virus is affected. I think it's pretty clear that there's an effect on brain abnormalities. It's important to keep in mind that it's not just a small head, but you can have brain abnormalities and a normal size head. So, there's a lot of variation in the diagnosis. In areas where you have Zika virus, all pregnant women need testing. So that's the important thing. All pregnant women need testing once Zika virus becomes prevalent in your area of practice. The PCR testing, genetic testing, only if you're within 2 weeks. Antibody testing for everybody else. Blood and urine should be sent. Ultrasound surveillance and being aware of the ultrasound findings is critical. And just sending the tissue for analysis after delivery and talking with your pediatricians about what the follow-up should be for baby. Okay, thank you.